welcome to the second of our ABC of CVD prevention during the COVID webinar series. This one's on blood pressure. Hope that's what you're expecting. I'm Vivian Williams. I'm a GP with a specialist interest in cardiology who works in Runcorn, and I'm the Halton CCG CVD lead. So we've got 3 talks on hypertension coming up. The first one is by Dr. Bruce Taylor. Then we've got one by Dr. Paul Bishop, and then Jane Briers from the British Heart Foundation is going to talk as well. During this webinar, the chat function is disabled, but you can use the Q&A section at the bottom for any questions that you want to ask, and these questions will be asked at the end. Hopefully this won't be adding to your workload, but will help give you things to help make your life easier, because we know how busy everyone is at the moment. So let's move on to our first talk. So this is a hypertension overview with Dr. Bruce Taylor, who's the Care Network Primary Care CVD lead for Cheshire and Merseyside. Thanks, Bruce.
Thanks. Can I just make sure that everyone can see the screen? Is that okay? Viv, can you hear that?
Yeah,
that's fine.
That's fine. Okay, great. Okay, so thanks. Welcome everybody. Good afternoon, and thanks very much for joining us. As Viv said, this is the second of our 3 series on CVD prevention. If you didn't get the one last week on atrial fibrillation a couple of weeks ago, that is being recorded, and you can. We'll give you a link at the end of this one, so you can watch that one in your leisure. And again, this one is being recorded as well, so you can look at it again if you want to. So let's just talk about the ABC. ABC does not stand for anything but COVID, although I'm sure you all agree, wish it did. It stands for atrial fibrillation, blood pressure, and cholesterol, and these are regarded as the 3 big risk factors for CVD disease. And I think that's absolutely right, although probably also I think whenever you look at people or you see patients in front of you, I think it's very important to look at other factors, if you like, the D, E, F and G, the lifestyle issues, diet, exercise, alcohol and smoking. I read somewhere, I think, that 1/3 of us have put on weight during lockdown. And so that's a significant risk factor in itself for blood pressure, as of course is alcohol and lack of exercise. This is one of my favourite slides. This is for those of you who don't recognise it because you're all probably far too young. This is Elvis Presley having his blood pressure taken. Elvis Presley, of course, was known as the king. But let me tell you something, he's not the king. Blood pressure is the king, okay? And that's, if you remember nothing else of my talk, I'd like you to remember blood pressure is king. And this little light bulb you see is what I call a top tailor tip. And whenever you see that, that's something that I hope you think is particularly important. But blood pressure is the king, and I mean that in the fact of all the risk factors, I think by far and away it's the most important risk factor. And this is an old slide now, but I think it still works very well. And this shows that high blood pressure, systolic blood pressure in this case, is without doubt the biggest risk factor there is, worse than smoking, alcohol, cholesterol, etc., in causing death and disability. So if you want to help people to prevent them getting heart disease, blood pressure is king. Look at their blood pressure. So some basic things. I know some of this will be well known to you, but 5 million people unaware in the UK that have got blood pressure, affects 1 in 4 of people. It causes at least 2 billion's worth of diseases to the health service, and 12% to the visits to the GP. This was taken, this slide really was pre-COVID. Obviously visits to GP are different now, but essentially it was a large component of our work. And here's the thing, blood pressure, as I said, is linked to most CVD disease. It's, if you like, it's the key risk factor in stroke, heart disease, including ischemic heart disease, heart failure, and atrial fibrillation, chronic CKD, and vascular dementia. So blood pressure is a really fundamental part of CVD prevention. And we know that if we manage to reduce blood pressure, we could save a lot of money. This slide, £85 million of health and social care. By that, I mean people in nursing homes because they've had strokes or heart attacks. And we also know that we need to look at 2 areas of blood pressure. One is in diagnosis, so 15% more people diagnosed. If we could do that, we'd save pots of money. And if those people were diagnosed, if we could actually get them treated better, we'd also save pots of money. And why does it matter? Well, we know that it's a very easy thing to treat blood pressure. We've got effective therapies. And I think when I mention therapies, I think it's very important to understand, I don't just mean drugs. Losing weight, exercise, stress reduction, alcohol reduction, these are all effective therapies as well as tablets for reducing blood pressure. It's fairly easy to measure. It's not a difficult thing to do. And you can look at how well you're doing. As I said, their lifestyle modifications are possible and they're effective. We've got good drugs for blood pressure. We haven't had many new ones for a while, but the ones we've got, we know they work. We know you probably should be giving them in combination, but they're effective. And also, this is a thing that Paul's going to talk about in a minute. It's a terrific thing for self-management. By that, I mean people buying or having access to low monitors, recognizing it, treating them themselves. And I honestly think, I always make a joke at this time, Christmas is coming up, and if people are looking for Christmas presents, buying each other a blood pressure monitor is not a bad way of spending a good Christmas gift, in that people can actually start to take an interest and manage their own blood pressure. And I think COVID, if there's been any silver cloud in the whole ghastly affair, is the ability of people to take more responsibility for their own health. And as I say, blood pressure is king in that. So that gets another top tailor tip. This is a slide you'll have seen before, I'm sure. This is the ambitions from Public Health England over the 10-year period. This was done in 2019, again pre-COVID. But the ambition there was to try and significantly reduce cardiovascular death, premature cardiovascular disease. And for blood pressure, that meant the target in 10 years was to get 80% of the people who were expected to have blood pressure, bearing in mind that's 1 in 4 of us, up to be targeted. And of those particular people who were targeted, 80% of them to target to a reasonable dose, a reasonable standard. And current NICE guidelines, of course, is 140/90, QOF being a bit higher at 150/90. But 140/90, and most cardiologists will agree that's a fairly minimal standard. And we know that if we did that, the ambition was that we would, first of all, for every pound we spent, we'd get it back in reduced cost to the health and social service system, but also we'd save 150,000 extra deaths. Now, COVID sadly cost about 50,000 deaths. So you can see the potential for CVD in saving many more deaths if we can get it right. So how are we doing in the area then? Bearing in mind the target was 80% target, 80% to get it to well controlled. And this is the SDP, or if you like, the whole area. And you can see that currently this is we have about 68% of people who we think are diagnosed in the area with hypertension. This again was 2018-19, which is the last slides we've got. And I worry, I suggest a bit that we might have, those numbers might be lowered, and I'll come back to why that may be in a minute. And you can see across the patch there's a significant variation. We are slightly better than the national average, but still we're only 2/3 of the people who we think have got blood pressure are known to us in primary care. And that's the gap in our area of about 71,000 people. And this is an important slide because this shows, you can use this for any disease, but it shows it for blood pressure. So we have some practices who are up to the 95% of their patients diagnosed, while we have other practices below 50%. And that's clearly, probably unacceptable is too strong a word, but that's clearly an issue of concern. And hopefully primary care networks will be able to help address why we've got such a variation. So what about treatment? That was about diagnosis. What about treatment? Well, it's about the same for treatment. So this is people who we think are targeted to 140/90, which is the current NICE guideline. And again, it's about just over 60% of the people who are known to have blood pressure are diagnosed to this level. So it's a big gap. Now, we have done well, I think, in Cheshire and Merseyside over the last few years. I mean, we've been working at it before COVID really hit us really quite hard. And we had 16,000 new hypertensive diagnosed, and we had 4,000 patients treated to a target in the last few years. And there was evidence before COVID that we were starting in the region to buck the trend of increasing ischemic heart disease to deaths, in part, I think, because we were starting to tackle risk factors such as blood pressure. But as I say, 68% of the estimated high blood pressure Cheshire are known to primary care. So to get the rate of 80%, which is what they want us to do by 2029, we have to find 71,000 more people. 58% known to a target of 140/90. we have to get to 80%. That's still only 80%. It's not 100%, 80% of target. That's another 100,000 patients. So the numbers are huge, and we're all very aware that with the COVID situation, that's a significant risk factor workload, and we're going to have to work a smarter way of dealing with that. This is something you may be aware of. Cheshire and Merseyside is very lucky. We have something called the CHAMPS, which is the Public Health Collaborative of all the public health services, and they've been working on blood pressure for a while. And Mel Roach has been leading the work on that. And they've been producing annual reports for the last 4 or 5 years. And this is a good website to look at, and you can see what we've been doing across the patch. And I'd strongly recommend that with a top tailored tip. So what about COVID then? Well, some stark facts. If you've got blood pressure, you have a twofold increased risk of dying from coronavirus compared to those who don't have blood pressure. So blood pressure is bad news if you have COVID. There was some worry, I think, early in the game that drugs like ARBs and ACE inhibitors, because they increase the expression of a protein that the virus used to latch on, would somehow have an adverse effect. But that has not been shown to be the case. So most people overwhelmingly now say, if you've got people on these drugs, you must carry on with them. I've mentioned again adverse lifestyle choices. So people are getting fatter, drinking more during a lockdown, and we obviously got the festive period coming up. And this is the one that worries me a bit, is the ability to opportunistically check people's blood pressure during COVID has, I think, reduced. I know in my own practice, we used to check everybody coming for a flu jab with their blood pressure. Well, that's not been possible at the moment. So I think we are starting to miss some opportunities to make new diagnoses. And I think Paul's talk on remote monitoring might mention that. And I'm also very conscious that everyone's working flat out at the moment. So we have had limited resources to look at regular review. So COVID has affected hypertension, but I think one of the purposes of all these seminars is to say to you, when COVID is over, we will have to get back to look at CVD. And it's very important that we just keep thinking about it and how we might do that in the future. So we have got some initiatives, and I'll briefly talk about them. We've got some national initiatives and some local ones. The national initiative I'm going to mention briefly, CBD Prevent audit, you might have heard about, and also the CVD DES. That's coming in April and will give money to PCNs, hopefully to do CVD prevention, and hypertension will be a large part of that. We're hopeful, although it's not yet confirmed, that they might give funding to allow each PCN to appoint its own CVD lead, and also hopefully some money for education, but that's not confirmed yet. Paul's going to talk about remote monitoring in a minute, but I think the evidence now is overwhelming that actually having your blood pressure or monitoring at home gives you better results than if you come into the surgery. So that's a massive, big shift in our practice. I think that will have to be reflected going forward. And also nationally, something called UCL Part. This is University College London partners. And I've put the link up. They've done a lot of work on long-term management tools, and I will mention that. And again, I know Paul's going to mention what they're doing at the moment. So there are national initiatives. Locally, we've been doing some stuff. There's something called the BPQI project. I'll talk about that, and Jane is going to do a session on that in a minute. And also, we've been lucky enough to get some funds for a digital first primary care bid, which is going to take place, and I'll come on to that in a minute. So let me just briefly talk about CVD Prevent for those of you not aware of it. So this is a national audit program that's going to happen in the spring, and it's going to look at 3 areas. So there's going to be a high risk conditions cohort. So this is people who've got known risk factors. There's going to be a second group of people who've got diseases. And there's a third one, which will be people who we think potentially have got diseases but haven't yet got that coded. So this will come out in the springtime. Practices will get information about their own practice, their own PCN, their own CCG. And the good thing about this will be real-time data. So this might help us to look very clearly at where the gaps are and what we need to be doing. So that's CVD Prevent, which I think you need to be aware of. The UCL partners, as I say, briefly just to talk about that, they've got these frameworks. They're virtual. The idea is that they utilize the wider workforce, not just GPs and nurses, but other people available in primary care. Self-management is the key to it, and obviously innovations with apps and stuff. So this is what they're trying to do, and those of you interested in it, I think this is a very important series of tools. They've got search tools that look through your notes to see your blood pressure patients. They triage them into low, medium, and high risk, and they recommend what should happen with each of those categories. And they've done it for diseases like asthma and diabetes, but they've done, as I say, this one for hypertension, which is quite good. This is their stratification. I'm not going to go through this in detail, but just to say there's different priorities, and the idea is that these priorities are then dealt with by different members of the primary care team. So this is just to let you know this tool is available. We're working with them. If you're a practice that might be interested in this, I know the Innovation Agency is helping to roll some of this work out, and I'm sure they'll be very happy to hear from you. So that's the UCL Partners tool, and well worth a look. The BPQI, again, briefly, I don't want to steal Jane's thunder. This was developed by CHAMPS, as I say, the Public Health Collaborative, and the charity she works with, the British Heart Foundation, a great charity. And it's a nurse-led system with dashboards and tools and protocols, leaflets and training. And we're hoping that that will be, will embed some of the UCL partnership work going forward. So that's a local tool that's very well worth looking if you don't know about it. And again, the digital first thing, this is the project that's only recently been given the green light. There's going to be projects, I think Paul's involved in the one in Cheshire, I'm involved in the one in Wirral, also in Liverpool and South Sefton. The idea of looking out, rolling out the BPQI and UCL, but also looking at different ways of monitoring patients, texting, getting them to phone their readings in. So it's an interesting way of using technology, and hopefully will give us some more resources to help support practices going forward. And CHAMPS are going to review it and try and make sure that any messages learned in one area is shared across the other. So final slide for me is about Happy Hearts. For those of you who don't know it, Happy Hearts is a, professional site and for patients, and it's got lots of good resources on there. And if you haven't had a look at it, I recommend you do it. And the final thought, the final top tailor tip, as I said at the start, if you're thinking about risk factors, if you're trying to help people, blood pressure is king. Thanks very much. Okay, is that okay, Viv?
Yeah, okay, thanks, Bruce. That was great. That was a really good like overview of where we are, where we need to go, and some really good local resources that hopefully will come in handy. I've looked at that UCL Partners tool. It looks really good. Hopefully that'll help in the future. The QOF date has now changed since that data came out, so they are now in line with the NICE guidance of 140 over 90 under the under 79s, 150 over 90 for the over 80s. But I'm sure everybody watching knows that anyway. The Q&As can keep them coming in. We're going to keep hold of them and ask them at the end. Next, we've got our second talk, which is from Dr. Paul Bishop, who's a GP and the CVD lead for the combined Cheshire CCGs. And he's going to be talking to us about remote blood pressure monitoring. So take it away, Paul.
Thanks, Viv. Bear with me while I bring up my slides to share screen. It should let me do that. So hopefully you can all see the title slide. So as Viv said, I'm a GP in Congleton, and also the lead for Thriving Prevention, which covers all the long-term conditions and elective work for Cheshire CCG. Home blood pressure monitoring. I've been using home blood pressures for probably about 2-3 years now, predominantly to monitor my patients, because it's in some ways it saved me a little bit of time, and it certainly saved the patient's time, the practice time, in popping back and forward when I've been up titrating or looking at the diagnosis of hypertension in my patients. And COVID certainly brought remote monitoring to the fore, because we are certainly in the first wave. There were hardly any patients crossing our doors, and even when you tried to encourage them to come down, they didn't want to. So it's certainly been an opportunity for certainly my practice to increase the experience with using it. So does it come with an evidence base? It does. It's mentioned in NICE's guidance that was updated in 2019. And I thought I'd start with just some levels, which I'm sure you're all aware of. So abnormal is 135 systolic and above. The difference again is in your staging. So 135 to 149 is your stage 1, and 150 and above is your stage 2. And NICE have helpfully put a nice little chart in there that's separate from the guidance that you can pin up on the wall, or your nurses can have, which again helpfully says for those that are deemed to be normotensive, when would you recheck their blood pressures? So if they're well under the 135 or 140/90 for a clinic, you would check them every 5 years, which is in line with the NHS health checks program. The caveat to that being where they're closer to it, or then you would check them a bit more often. And hopefully that'll allow us to have a little bit more standardization across the practices as to how we do this. I've certainly found within my own practice, what I ask for and what my colleague in the room next door asks for is different. So it's something that we need to think about. So again, diagnostically, the gold standard is using ambulatory blood pressure monitoring, but if your areas are like mine, trying to get an ABPM, practices may have 1 or 2, may have none, or you've got to refer up to the hospital for it. And then again, with COVID, is there restriction on how often do they have to clean them down after every patient? Do they have to use disposable cuffs? So practically using ambulatory blood pressure monitoring becomes problematic. Therefore, home blood pressure monitoring is probably the pragmatic way for us to go forward. And again, NICE clarifies what is home blood pressure monitoring and how to do it in a very simplistic manner. So 2 consecutive measurements, minute apart in a rested, seated patient. And you do that, they take the best of those results and you record it twice daily for 7 days. Then discard the first day's readings and then average them out. And the patient supplies that back to the practice. What I've actually found is that the British and Irish Hypertension Society is a tremendously useful resource for people to use because it has some very good patient information leaflets. So one is just around how to use an automated blood pressure monitor. And I would just put a caveat in around automated monitors in your choice of which patients to use it in. So if a patient's got AF, as far as I'm aware, none of the monitors are validated in AF for the blood pressure values. So I would be very cautious in using an automated blood pressure monitor in a patient that's got AF. There's certainly a very good patient information leaflet. That's the one on how to use an automated blood pressure monitor. And then actually there's a second leaflet from them, which is about patient level, how to take your blood pressure at home. So a single side of A4. I've given it to several of my patients and they found it fairly straightforward to read and they're all comfortable with that. The issue comes around actually the patient getting a blood pressure monitor. So my practice, we have 7 that we loan out to patients for a week. I also suggest that patients buy a monitor. And again, on the British and Irish Hypertension Society website, there is a link to a list of blood pressure monitors that have been validated, ranging from £20 to whatever you want to spend on it. Again, I would probably suggest to my patients there is absolutely no need to spend an arm and a leg on a blood pressure monitor when the £20 one will probably do exactly what I need it to do. There's, as well as the single-sided A4 leaflet, there is another leaflet on that site which gives a rationale for why we do home blood pressure monitoring. This guide to how to take your blood pressure at home, and also a monitoring sheet for the patient to fill in. Now, I've been using Accurix with my patients so that they can just text me once I've sent them the link, their average for their blood pressure. And then I'll be texting them back or phoning them back to discuss whether I need to up titrate or down their blood pressure medication. And I think that's quite a key point. A lot of this we cannot do just purely on the monitor value alone. When we're doing up titration, we should also be asking questions around postural hypertension. And are they symptomatic? And I think that's really important with them, especially in patients with other comorbidities like heart failure, where you're up titrating. Almost all those drugs have a potential to make patients hypertensive. So it's being conscious that we have a value, but also we've got a patient, and the patient has to live with those drugs that they take, and some of those drugs that we take give them side effects. So asking those questions as well, and using AccuRx or one of the many other means of virtual communication with the patient, or actually just the plain old telephone, which can be done with a nurse, to phone them and ask. So as I said, British and Irish Hypertension Society is an excellent resource, as well as the NICE guidance itself. So where do we treat to? So again, I think Bruce has probably already mentioned adults under 80, 135/85, and adults aged 80 and over, 145/85. Again, we need to use clinical judgment in some of our elderly patients who are quite frail. I say elderly, most are, but we do have some younger patients that are quite frail and prone to falling. So using what GPs are really good at, a bit of common sense, and managing their patient's blood pressure to the lowest level that provides a safe care for the patient is appropriate. Finally, I've included on the slides the link for the accredited blood pressure machine, and also the link to the NICE guidelines, so that when we share these slides, you can use these put them onto your desktops, or just download the documents and then use them. But certainly from experience, I've found over the last few years, and certainly in the last 6 months, patients are really quite keen to take on board their own monitoring. They regularly supply it when I ask them to supply it. And it's often been quite well accepted to provide me with their blood pressures. It saves them a journey up and down to the practice, reduces the burden on my practice nurses, and actually it reduces the burden on my consultations, because often I'm doing this through AccuRx in between times, and what previously would have been in a 10-minute GP slot is actually been undertaken in 5 minutes via text or less than that, especially when I know the patient quite well. As Bruce has mentioned, the UCL have some pathways around hypertension for risk stratification, and also some pathways around questions to ask and what to do. I don't intend to go through the UCL slides. It's only have 10 minutes, but again, I've included them in the presentation, so there's something for you guys to have a look at and consider whether it may be appropriate within your practice or within your PCN to look at these. And that's me, Vivian. Thank you.
That was great. Thanks, Paul. I liked the common sense approach to remote BP monitoring. I also found it's not just AccuRx, but e-consults. There's a specific e-consult for blood pressure monitoring, where the patients can enter in their own data, and then the e-consult works out the average blood pressure for you. It's brilliant, requires much less use of a calculator.
I'll have to remember that one, Vivian, because I often have my calculator out for that.
Yes, sometimes it's hard to persuade the patient that they want to put in all their details, but it's much saves time and saves a bit of brain power for that. So next up, Jane Byers has pre-recorded a session about the BPQI approach. Jane's the CVD Clinical Development Coordinator for the British Heart Foundation. Unfortunately, she couldn't be with us right now, so she's recorded her presentation in advance. So any specific questions for Jane, we can try and get to her later, but we won't be able to answer the questions immediately. But if you do have any questions, please put them in the Q&A box, and we'll answer them later. Thank you. So over to Jane.
Yeah, hold on a second.
Hello everyone, my name is Jane Byers and I currently work with the British Heart Foundation, and I've been part of the team that's been working on the blood pressure quality improvement toolkit, or BPQI we call it for short. Certainly when we started the looking at BPQI, it goes back to about 2016-17, and we initially really wanted to hear from practitioners on the ground what was needed to try and improve the quality of care around hypertension. So we did what's called a KETSO workshop, which was supported by NICE, to speak to a considerable amount of practitioners out there. And we got some quite clear feedback, and that was that certainly there seemed to be a need for tools to support good practice. We were told that a lot of the hypertension management in general practice is conducted by nursing staff. But obviously there's this mixed skill set there, from a really experienced advanced nurse practitioner to a healthcare assistant that might be new to the role. So some tools were needed to try and support that skill mix. And more recently also we have clinical pharmacists coming on board as well. We were also told that practices didn't have the ability to benchmark themselves. Certainly within QOF data, you know, that's one simple tool, but it certainly doesn't give you a full overview. So we looked at developing a dashboard to try and support you with that, and I'll talk a little bit more about that later. And also there was a request for easily accessible information for patients, and for patients to know not only the current blood pressure but also what it should be, alongside training and support. But what came clearly through from that workshop was that just doing a half day training afternoon would not actually result in perhaps the outcomes that we were looking for, particularly as staff leave and come and go, or they move around to different practices. So we needed to try and develop something that helped people as they were doing the work, really. So the BPQI kit was formed based on that, and we can demonstrate both quantitatively and qualitatively that it improves care and control of blood pressure, and also that it's popular and well liked, which I think is one of the most important things, really. If things take too long or practitioners don't enjoy using it, then it's not going to be used regularly. But certainly we do have that feedback that practitioners find it really, really useful. So it does consist of 4/5 main components. The first is a template, and as I say, that's been designed with nursing staff in mind and clinical pharmacists. We wouldn't necessarily expect GPs to be filling this element in. but as I say, designed by nurses for nurses, and it does contain guidance around what your blood pressure should be, when red flags are. So, for example, if someone's walking around with a screamingly high blood pressure, it'll tell you at what point to escalate that up. There is also a dashboard, and that will benchmark you against NICE quality standards, and it'll give you an awful lot of information, and I'll explain that a little bit more a little bit later on. Naturally, there is a practice protocol as well that's available both in electronic and paper format, and that will guide you through from both the diagnostic elements of hypertension and also optimal hypertension management too. And then we have what we call a patient information prescription, and that just gives general lifestyle advice, but alongside a quick hit of the F12 key, you can produce the patient's current blood pressure and what it should be for the patient to take away as well. So just looking at this in a little bit more detail, as you can see, we've got, this is a screenshot of the template. And as I've said earlier, we've got the sort of the criteria for ambulatory and home blood pressure monitoring in stage 1 there. And we've also got red flags around things that might be typically missed as well. So, for example, in this screenshot, we've got if you're under 40 years of age with stage 1 hypertension, that perhaps we should be thinking about referring that patient on. Moving forward into the dashboard, and that's just a closer look as to what that looks like. I think actually the format of this will change in the future. We are just in the process of making all of the BPQI toolkit COVID friendly. I think we both need, we all need to acknowledge that probably the system's changed quite significantly. So we're trying to align both the template and the dashboard to reflect the new world that we're working in. Also, we have the protocol, and that's just a snapshot of a flow chart of the diagnostic process and what you should do there. But as I say, there's plenty of flow charts in there. There's also links to patient information around taking an accurate blood pressure reading at home, and all of the kind of information that you might need. There's checklists and all kinds of useful info contained within that protocol as well. And that, again, is just a closer snapshot of the patient information prescription. And it just describes what blood pressure is and lifestyle advice. There's also the opportunity there for you to add in links to your own local health systems. So that might be you want a link through to your health and wellbeing services locally, and that they can easily be added into the template, into the information prescription too. So the template, it does follow the pattern of a good quality clinical consultation, and that's sort of more of a nursing consultation. So it just does generally follow that flow really. As I said earlier, it's targeted at nursing and pharmaceutical staff, and it does cover both the diagnostic and the review process clearly. I think one important thing to note is that if you should decide to take up the BPQI toolkit, I think experience tells us that when staff first see the template, it looks very heavy and very time consuming, but that's only at first glance. So you can see there, just on the snapshot there, that we've got the diagnostic tab, we've got a hypertension review, lifestyle, smoking status. So you wouldn't necessarily be filling all of those in at every review. But what it does do is, depending on how your practice works, you might want the pharmacist to do the medication review. You might have a health trainer looking at lifestyle, so you can just click into it as you need to. So don't be put off. Once you know your way around this template, it is really, really supportive. The other thing, just to add, as I said, it's enabling you to have the information you need at your fingertips. So under the references tab at the bottom, you can also see information around some of the more unusual circumstances. So, for example, it'll give you the target blood pressure if you've got kidney disease, or if you've recently had a stroke, all of the things that you should probably be aware of but might slip your mind during the consultation. It just provides you with everything that you need. When you actually open up the template as well, you will see on one page all the blood results, ECG, everything you could possibly need to know about that patient is presented to you quite clearly. So you can easily see if someone's not had, say, the kidney, the usinase checked regularly. You can see that straight on one page without having to go searching for it. The dashboard, as I mentioned earlier, it does benchmark against NICE quality standards, and it does give you your observed v expected prevalence. It does support you with case finding, and I think this will be particularly useful if your practice is playing catch up following the pandemic. Just that, if you can see the little box at the bottom, that will enable you to triage your patients. So it will pull out people whose blood pressure is on last reading greater than 180/110, and it'll triage it down so you can actually see how many patients you've got. The dashboard does also allow you to click through, and you can see the Excel sheet that sits behind it. So you can see the patient's name, you can see everything about that patient that you need to know, such as what the Q risk is, what bloods they've had done, what the BMI is. You can see every bit of detail that you should want to know about that patient. And you can also filter that and change it as your practice sees fit, really. But alongside that, if you didn't want to go into too much detail, you've got this overview of how you're doing, and you can also track your trend. So that those bar charts that you can see there, they are the NICE quality standards. So you can see how you're doing now against, if you can see sort of like little red marks there of how you've done previously. So you can actually begin to follow your trend and begin to see the improvements that you're making once you've implemented the BPQI toolkit. So it is very useful, and you can personalise that to give you as little or as much information as you want it to give you. As I've said before, that's just a snapshot of the practice protocol. I'm not going to go into too much detail about that because I think it's quite self-explanatory. Perhaps the only thing to mention is that the protocol is designed to be gold standard, and it might take you, quite a while to implement the full findings of it, the full suggestions within it. But it's there to give you everything that you could possibly need to improve your quality of care in hypertension management. And as I say, we've got the patient information prescription as well. it does highlight the importance of concordance, and as I mentioned before, it does give key lifestyle messages. One of the important feedback that we got from the workshops we held at the beginning is that it needed to be on one side of A4, and we have decided to put it in black and white, conscious of printing ink. So we've done that, but also I think we're looking at getting some more coloured leaflets available if that should be a request. And one thing that I haven't mentioned is that we do also have a CCG level dashboard, but when I say CCG, that can cover an area of your choosing. So it might well be that you might want to arrange that at PCN level. It gives you pretty much everything that the practice level dashboard does, but obviously at PCN level or CCG level, it doesn't give you patient information. All the information is anonymised. It also has the facility to, if your CCG is asking around practice prevalence, it will pull all of that data and you're able just to send that in a patient anonymised format straight through to the CCG, so that you don't have to spend a considerable amount of time asking your staff to pull together a spreadsheet with the information that they've requested. It's all there and done for you. We do have a walkthrough of the toolkit in action, and that's a video walkthrough of how that you can load it up. We also have written guidance to that. I'm not going to play that now because it'll take too much of your time, but that is available to anybody that wants to take a closer look. And just to summarise really, I just thought I'd feed back to you some of the quotes that we got from people that are actually using it. So we've got it structured in easy steps, and that really helps the healthcare assistants. The support page is really useful. Practice managers and IT support are great for helping to run the reports. Certainly, I think many practices now do have some form of IT support. And to be honest, loading templates and running a dashboard isn't that difficult. But again, we're looking at ways and means to support you to try and make that happen if you can't manage that yourselves in-house. Certainly, we also had quotes that it's a useful tool in the clinic to identify patients not managed properly, and it helps with quad figures too. So that's a quick rundown of the toolkit. And as I said at the beginning, I'm more than happy to follow this up with email or a telephone conversation. So I'll make sure the rest of the team have got my contact details. Thanks very much.
So that was a great overview from Jane telling us all about the BPQI tool. I don't know if any of you have seen it. I've used it. I do think it's a very helpful tool. It can look a bit overwhelming, as Jane said at first, because there's quite a lot to it, but I know that our HCAs who've used it think it's excellent. We've got a couple of minutes at the end now for any questions, so if anyone has any last minute burning questions, just type them into the box, otherwise we'll start working through with what we've got. So let's have a look. I guess go on then, Bruce, you can tell us all about anyone who's you've talked about how in the UK hypertension is being dealt with. Who should we be looking to do it better?
Thanks. Yeah, I always think that the world leaders in hypertension are actually Canada. And if you ever get the chance to go on their website, Canada Hypertension, they've been at it for a long time. And I think they've got their detection and management rates up to in the high 70s. If you remember what I said in my presentation, the target for our government is 80%, which I think is great. It's incredibly ambitious unless they throw a lot more resources at it. But in Canada, you can go into a supermarket, you can go into a petrol station. I mean, this is obviously all pre-COVID, but everybody is really fired up on blood pressure. So there's a great public awareness that blood pressure, you know, is an important thing for everybody to get involved in. And they've got a good website with some good resources on, but they are doing it and have been doing it for a while, and they will get the benefit of it. I mean, I think that's the thing with blood pressure. Unfortunately, work you do with blood pressure now, you will probably have to wait 4 or 5, 10 years to make the difference. But they are now starting to have quite significant reductions in their CVD death rate. So Canada is the place I would, you know, I recommend it for a holiday, but I'd also recommend it for looking at how we should be doing blood pressure.
And I'm sure a great holiday would be good for your blood pressure, if nothing else.
Absolutely, certainly.
I mean, I think it's great that that you can now get your own blood pressure monitor for like 20, 25 quid. And they're validated for 5 years before you have to get them recalibrated again. And I think that's.
Yeah, I think just on monitors, I mean, I think there is pressure that to try and make them available on prescription. I mean, I always think it's a bit crazy, £20, £25 for a blood pressure machine, which hopefully will last you 5 years, and a steroid inhaler for asthma, £28, £30 or whatever. So I'd like to think that in time, there'll be pressure. I mean, I don't know where the block is. I suspect it's with pharmacy companies. I don't know, but I honestly feel that we need to try and keep pushing on that. One of the questions, sorry, Viv, that I noticed that I don't know if we answered was the one about BME problems. And I think that's a significant issue in that BME patients seem to be disproportionately affected with blood pressure, particularly Afro-Caribbeans, I think. But there's a couple of things on that, I think. One is people beware of NHS health checks that's been going for a while. And there's big plans, I think, to relaunch that post-COVID. And there's a great awareness, I think, now because of COVID, of looking for people, particularly BME communities, but others who are at higher risk. So I think we'll find that the health checks, when it comes back, will have some specific targeting of those communities. And the only other thing that I'm aware of, I mentioned it briefly, there's this CVD DES that's coming in April. And again, what I understand is that there will be particular emphasis on targeting the ethnic population. And I think that's really important. Locally, I don't know, but it may well be that there'll be some local variation in the PCN, in the DES, and it may well be that various CCGs will look specifically at their areas to try and bring those figures back up. But they've definitely, it's very interesting why COVID seems to have affected BME patients more. Some of it, I suspect, is socioeconomic poverty rather than just genetic factors, but also I think blood pressure may be a key factor in one of the reasons why they've done so badly, or seems to have done so badly.
Great, thanks, Bruce. And pharmacist involvement. I think there's lots of pharmacists being moved into practices locally. I know I work with some great pharmacists. I think they would also be great at helping us with hypertension. I think they would. I think they'd be good, but at the up titration and medication monitoring, but also, if you like, your local high street pharmacists and stuff. There was a good push by Mel before COVID to get a lot of pharmacists were trained. I think it was called the Living Pharmacy Project. So you could go and get your blood pressure taken in pharmacies. Obviously, again, COVID has completely put the can on that. But hopefully, as we move out of that, we'll get pharmacists again more willing to take blood pressures and get involved in it, because we need, as I said, we've got 71,000 people out there, probably more, who actually are undiagnosed, and 100,000 people who are probably inadequately treated. So there's a huge workforce. We cannot do it all in primary care. We just simply can't. So we have to get more people, more resource. That may be pharmacists, it may be all sorts of folk within the practice. But critically, I think it's going to be patients, and that's where I think the remote monitoring is going to work. And there's a very good, if people are interested in studies, the Tasman study done by Professor McManus, the latest one,
shows very clearly that people who actually monitor their blood pressure at home have better long-term outcomes than those who used to come regularly to the surgery for us to measure it and change their treatment. So self-monitoring is actually, not only does it work, not only is it cost effective, it's empowering, it actually bloody works as well.
I think also those who take control and do their own monitoring are also better at adhering to their medication. They seem to be more, because they're more involved in the whole process, they understand why they're taking it.
I think they are, they're much more motivated. I mean, the difficulty is, and this is the thing with all digital technology, is that that will help a certain proportion of our population. The danger, of course, is that the other groups of people, again, socioeconomic, maybe the same, who are going to be miss out yet again. And that's always the danger. If we invest just in digital technology, we're going to disenfranchise those people, maybe the elderly, who really can't understand these things at all. So we have to be careful we don't miss them as well. I mean, digital technology is great, but if you're getting old like me, it becomes a bit harder.
Yes. Now, we've not had any more burning questions that have come through. So is there anything else you'd like to comment on, Bruce?
No, as I say, I think it's just the whole point of these sessions is not to say to practice, will you please go and look for your blood pressure, because we know they're very busy. It's just to make sure that you're aware that we need to get back onto this as soon as we can, and we need to work out ways of supporting and helping. The BPQI tool is going to be great at that, for those who haven't used it. The UCL Partners tool will be great at that. And we need to be cleverer and working with PCNs to train people up and to support practices and get the message out to patients. So this is just, if you like, to keep people thinking about blood pressure before, you know, when we get round to it. And remember, blood pressure is king.
Yes, I love that. Blood pressure is king. And I enjoyed your tailor top tips.
Tailor top tips. Blood pressure is king. Thanks very much, Bill. Thanks very much, everyone, for coming. It's been great. We've had good numbers, and we're really delighted with that. Yes,
thanks everyone for giving us your time, and thanks to everyone who's spoken today. Hope you all have a lovely afternoon, and looking forward to our next, the third one of the ABC, the cholesterol talk, in 2 weeks' time, same virtual place possibly, but maybe not. Who knows nowadays? Anyway, have a lovely afternoon. Bye.